All right, welcome to the Explainer. Today we are heading deep inside the most complex machine ever known, the human mind. And we're going to look at what happens when that intricate machinery starts to fail.
So think of the mind as a machine. What happens when the gears start to fail? Now, for you as a future nurse, this question isn't just some academic thought experiment. No, it's the absolute core of your mission. You're going to be the master engineer of patient care. So, okay, let's get our hands dirty and dive right in.
All right, first things first. Before we can fix anything, we've got to understand the schematics, right? We're talking about neurocognitive disorders, or NCDs for short. And what are they? Well, simply put, they're a whole class of conditions where the main problem is a big, clinically significant drop in cognitive function.
Now listen up, because this is the crucial point. This isn't about how someone has always been. It's not their baseline. It's about a loss of function. It's a decline from where they used to be. And the DSM-5, our diagnostic manual, lays out a whole spectrum of these disorders, and believe me, we are going to deconstruct them.
Okay, so you're the engineer on the scene. Your first job? Diagnosis. You have to be able to tell the difference between two totally different types of system failure. On one hand, you've got this sudden, violent electrical storm we call delirium, and on the other, you have the slow, creeping, inevitable corrosion of dementia.
Just look at the contrast here. It's absolutely night and day. Delirium, that's a full-blown medical emergency. It's an acute crisis. But dementia, that's a long, slow, chronic battle. Everything you do, your entire plan of care, it all hinges on you knowing the difference. Is it a sudden storm or is it a slow rust? Think of delirium as the machine's main alarm bell, just blaring. It's a chaotic system overload. And here's the key. It's secondary to something else. Maybe it's an infection, malnutrition, maybe substance withdrawal. Your job is to be the detective, to find the source of that short circuit, and you have to do it fast. Find the cause, treat it, and just like that, the storm passes. Dementia, though, that's a whole different beast. It's a slow, grinding decay of the gears themselves. They're rusting away. So your goal completely shifts. You're not talking about repair anymore. You're talking about maintenance and compassionate management. You can't fix this machine, but you can help it run as smoothly as it can for as long as it possibly can. So let's drill down into the most common form of dementia, the one you'll see the most, Alzheimer's disease. We're going to take a closer look at this rusting mind and see just how complex the clinical picture can get. And this timeline, wow, it just perfectly illustrates how this disease works. It's a slow, unwinding journey through this labyrinth of cognitive loss. What's so scary is that it starts silently. Brain changes are happening, but there are no symptoms. Then, it just slowly, piece by piece, dismantles a person's ability to navigate their own life. Now, as this incredible machine starts to fail, the mind does something fascinating. It throws up these shields, but they're faulty safeguards, right? We call them defense mechanisms, and they're there for one reason, to protect a super fragile self-esteem from the absolutely terrifying realization that it's breaking down. Take confabulation. This is so important to understand. The patient is not lying to you. This isn't deception. It's the mind desperately trying to patch holes in its own programming. So you might ask, how was your morning? And they'll tell you this incredibly detailed story. That never happened. Why? Because the truth, the gaping black hole of I don't remember, is just too painful to look at. So you might hear something just like this. Of course I remember. I was captaining my airship to the moon when the clock struck 13. It's vivid. It sounds almost plausible, at least to them. But it's totally disconnected from reality. Now, your job here isn't to argue. It's not to say, no, you weren't. Your role is to gently, carefully reorient them. Then there's perseveration. This is exactly like a gear in the machine getting stuck. It just repeats the same motion, the same word, the same phrase, over and over and over again, because it literally cannot shift to the next function. It's a coping mechanism when the mind just can't process what you're asking it to do. Okay, so we've seen the machine failing. We've seen the mind's faulty attempts to protect itself. So what can we do? Well, now we head to the alchemist's bench. We have to be clear, we cannot reverse the rust. There's no cure. But we do have some potent formulas, some potions, that can help manage the symptoms and slow down that decay. Welcome to your pharmacology.
All right, this table, this is your alchemical grimoire. You need to know this inside and out. But pay special attention to that exam alert column. This is the stuff that separates the nurses who pass their boards from those who don't. For cholinesterase inhibitors, like donepezil, the big scary thing is bradycardia. That's a dangerously slow heart rate. It leads to syncope, fainting, and falls. And that is why we give donepezil at bedtime, to minimize that risk during the day. Then you have your NMDA antagonist, memantine. The trap here? Dizziness, headache, confusion, which all adds up to a huge risk for falls. These are the gotchas you absolutely cannot afford to miss.
Okay, so we have these powerful formulas, but how do they all fit together? Let's try to visualize the complete treatment schematic.
Okay, here's the master blueprint. The central problem is pretty clear: cognitive and functional decline. But this malfunction breaks down into two different pathways. In early to moderate Alzheimer's, it's an acetylcholine deficiency. Think of acetylcholine as the lubricating oil for the gears of memory, and we're running low. But in moderate to severe stages, we're fighting something else: glutamate excitotoxicity. Glutamate is supposed to be the accelerator, but now there's way too much, and it's becoming toxic. It's literally burning out the circuits. So it makes sense, right? We target these two different pathways with our two main classes of drugs. For that first pathway, the low oil, we use cholinesterase inhibitors like donepezil to boost the acetylcholine levels. But then, as the disease gets worse and that glutamate accelerator is stuck to the floor, we bring in the NMDA antagonists like memantine to protect the circuits. And yeah, often we'll use them together, in combination, to fight this thing on two fronts.
But you have to remember, every powerful potion, every formula, carries a risk. And on our master blueprint, those warnings have to be etched in bright neon red.
And I'm not kidding around. If you ignore these warnings, you are looking at catastrophic system failure. That bradycardia from the cholinesterase inhibitors, that can be absolutely deadly, especially if your patient already has a heart condition. And the dizziness and confusion from the NMDA antagonists, that leads directly to falls. And a fall can be a death sentence for this population. Your vigilance, you watching them, is the ultimate safety mechanism.
But your job goes way beyond just handing out these alchemical formulas. Your primary role is that of the master engineer. You are structuring the patient's entire world to guarantee their safety, their function, and most importantly, their dignity.
So here they are, the engineer's 6 directives, and these are your non-negotiable protocols. I want you to think of it like this: you are literally retrofitting a world for a mind that can't handle the one we live in. You engineer safety. Get that patient near the nurse's station, get rid of confusing mirrors, put in those bed alarms. You maintain the schematic with a consistent, predictable routine. You recalibrate reality with big clocks and familiar photos. Every single one of these steps is an active, engineered intervention. It's how you support that failing system with both expertise and pure compassion.
Look, this right here, this is the core of your practice. The drugs help, for sure, but it's your engineering of their environment that will truly define their quality of life. You're not just a nurse, you are an architect, creating a safe world that a failing mind can still navigate.
So that brings us to the final and honestly the most important question. As engineers of care, how do we maintain the humanity inside the machine even as its gears grind to a halt? The answer isn't in a textbook, and it's not just in your skills. It's in your ability to look past the failing machinery and see the person who is still in there. That's the real art of what you do.